usually with this hand, TL, the right or left SI, and a lot of times the muscle will move. And that's where your correction is, right? Remember that. We've had a couple sessions. You can do that with, it's hard to do that with Cat 3 because it's a full TL. Cat 1 will, you could have a patient in gait and they're failing the inhibition test. So as best you can, keep them in the gait position and do a two-handed TL. If it's Cat 1, then the inhibition test will normalize. So, are we up? Do you guys want to do those muscles? Well, I want to do the muscles again, but I want to go. First, I want to. Some of you had weak sacrum spinalis. Yes. Who had? You did. I know. You were bilateral. I think. Who else? Let's see. 2. It's not many. It's pretty good. Who had a weak QL? You had a weak QL. Yours was bilateral. Yeah. A lot of more weak QLs. Looks like weak QL. Who had weak ankle muscles? Here's you go. Anybody have dramatically or really obvious? You did. Which one? Tip anterior. On one side. Is that it? Nobody else? Somebody had bilateral tip posteriors.
She's not here today.
Probably couldn't, yeah, she's probably sleeping in. Her adrenals are probably. Okay, so I want to, are you guys good with disc? I want to talk about cervical disc before we, are you pretty good with lumbar disc concepts? So we talked about category 3 in the AK, and it comes from SOT thinking, but it's really a dysfunction of the L5 S1 articulation between the L5 disc and the S1 and the sacrum. That's really what the problem is. And often you'll have a category 3, which will be a herniated disc, and it may not respond to correction because it's acute enough. And sometimes you have to let acute, disc has to kind of calm down. You have to kind of leave the person in antalgia for a while because the body kind of knows what it's doing. That's it's tempting. It's always tempting to get people out of antalgia, but sometimes they need to be left there for. Antalgia is interesting because we talked about where your facet patient is going to hurt them to go into extension, or even sometimes go into neutral. A lot of times your facet person's like this, where the disc person is almost always going to be more like this. They're going to be trying to seek out a position of extension to take the weight off. And often they'll be lateralized too. So if I have someone who's got a pretty distinct, postural distortion like that, a lot of times I put them down flat on a table and everything goes wonky. Their bodies, so I'll actually have to put them in some semblance of that distorted posture, and then they'll start. Then I can get in. I can do articular lock. I can check meridians and look at that. Like you talked about yesterday a little bit with body into distortion. Sometimes body into distortion means you put them in a position that their nervous system has been accustomed to. That's kind of how the nervous system is new set point. We don't want that to stay because it's kind of goofy to walk around like this, but you have to honor what the body's trying to do first sometimes, and then see what it's going to take to unravel it. Anyway, so cervical discs. Honestly, it's another one of those things where let's get up to cervical. Cervical discs, frank herniations are just like in the lumbar disc, not near as common as really acute, nasty neck problems that probably involve the disc, but they're not like frank herniation. Right, we got it. Back up. So some of these, so if you think about cervical subluxations, you know, we have fixations in the pillars and in the facet joints, which typically are felt and treated as posterior fixations. Usually we adjust in such a way to increase the glide of those facets, to free up the facets that have kind of rocked back like this, speed front, speed back. But we also have, anteriorities, and interiorities are where the vertebra is trying to slip forward, and usually the scalenes are out of balance. There's usually been, chronic strain in the neck, but without good strength in the scalenes. So you'll get this kind of like jamming forward of the lower cervical spine. So that's like chiropractic manipulation thing. If that gets bad enough, long enough, it becomes hidden cervical disc problem. Because the disc is where, when a vertebrae is kind of jamming forward, it's the disc that is the movable part. It's the part that's giving way. It's the part that's under abnormal strain. So over time, just like in the lumbar, that abnormal strain starts to fray and break down the fibrous integrity of that disc. And then it loses its ability to hold on. And it loses its ability to hold its shape. Then you've got disc loss, and then eventually you've got the vertebrae trying to grow its end plates out to stabilize that unstable disc. And then eventually, it may fuse. That's what we see on X-ray. We see these bone spurs coming out, and they're trying to stabilize this unstable disc. And very often, the bone spurs have been there. Bone spurs have been there long before the patient starts having symptoms or having the degree of symptoms that brings them in your office. That's kind of, and you guys know where the most common levels of disc degeneration are. Two main areas in the spine. L5, C5. Now, C4 and C6, certainly. C5 is the first to go on all distances. L5 is the first one to go in the low back. Now, you can have degeneration anywhere in the spine, but it's like C5 and L5 seem to have a marked correlation. And think about it, muscularly, they're two of the less supported areas of the spine. Down in the area of L4, L5, S1, there's not much muscle there. It's pretty much all fascia. It's all reliant on kind of spring tension of the fascia. Same at C5. C5 doesn't have a ton of big muscles supporting it. The big muscles attaching above it, upper trap, SCMs, but there's what's supporting the middle and lower part of the neck are relatively small muscles, scalenes, little slips of the sacrospinalis. So anyway, it allows, with bad posture, what happens, it allows this to happen. The head glides forward, and the C5 rocks this way. So, and then the muscles tighten, and the C5 does this. And so you could be anterior on both sides, or in the case of someone yesterday, who had the C5? Yes. It was on the right. So it's affecting her shoulder, or how is that today?
My arms didn't go numb.
Go ahead.
My arms didn't go numb at night.
It did? It didn't? Oh, okay, good. So maybe, good, because it moved well. I thought. Made my neck feel better. Moved that well. So anyway, any questions on cervical disc? Any of you had a known disc injury? You're all pretty young. You?
Yeah, I have.
Really? From accidents or?
Yeah, I got rear-ended. I was coming up and on the highway.
You got rear-ended? How long ago was that? Last March. Oh, wow. And you were diagnosed with issues. Really? Test you?
Do you know if they were there before the accident?
I don't know if they were there before the accident, but I definitely had whiplash from that accident because I didn't have any like physical symptoms before that, but I started having numbness and tingling and like shooting pain down my arm and like weird funky stuff. Like my shoulder is like all hypertonic and raised, and Cole fixed my first rib yesterday. That felt great. Everything is like elevated over
Did
here.
she have a limbic? Okay, so I'm just gonna get, my hands are still cold, so I apologize. That's a good question. I mean, if you don't have prior imaging, MRIs, yeah, it's just anyway, it's like if a tree falls in the forest.
But they did cervical traction, and the numbness and tingling went away. But my neck is very unstable.
So, and you're right-handed?
Yeah.
Okay. So if you put your arm just like that, down. She's pretty strong, but yeah, but that one's rock solid. So here's how I would approach an anteriority. This is, and I see these a lot. I will use the long head triceps. We're going to test her wrist extensors and finger extensors too. And then I'm going to go to the neck. And it already feels like it's kind of like this area here feels like it's kind of like this. It's like, if I can, you know. So that means the scalings are off. It's probably back right there. Is that tender?
Oh yes.
Yeah. Compared to here?
Yeah.
This is much more.
Yeah.
So, let's test your wrist. And we won't have to, I won't adjust it. We'll just, I mean, you probably had it adjusted, but. You get right respiratory adjustments on it? Or?
No, mostly just like regular.
Regular, and that does okay?
Yeah.
Okay. Up there, bring your wrist back. It's pretty good, actually. Elbow straight.
I definitely recruited on that one.
Yeah, okay. So, not bad, but, get your fingers up. So a lot of times the fingers can't really hide. Now we go on this side just to compare. This is the tricep on this side was good. Your wrist back and hold. Yeah,
That's
very good. And bring your fingers. Yeah, see that's normal. Okay, so if you guys remember, yesterday it was getting kind of late in the day. Talked about neck or head into distortion. I just start feeling gently moving the vertebrae and just kind of seeing like it feels a little bindy there. So I kind of go here, it feels less bindy. A lot of this is just feeling the motion at each segment. Stuck here.
Yeah.
Wow.
My C2 is almost always out.
Okay, interesting. Okay, so it's trying, so you know what attaches to C2, of course, longissimus certicis. And then also, of course, the rectus capitis posterior major. And what's the other one? The obliquus capitis inferior. Those attached to.
Oh, that's tender for sure over there.
So I'm going to have you start with that. Keep your head just like that. Squish. And that's better. And that's not quite as better. And let's try a little bit of that. And that's better. Keep your head like that. Bring your arm out. Make a fist. Elbow straight. Here. And it's kind of better, but okay. Now arch your back a little bit. That changes things. Right there. Try that again. And bring it up. Make a fist and fingers. Yeah, that's better. Feel that?
Yeah.
Yeah. So right there, we've got normal lordosis here, left rotation, and so if she walked around like this, she would be pretty well
Which
balanced out.
I do notice me tilting my head to the side sometimes.
I just want to hang on. Left shoulder is high. You said that too, right?
And that's probably really hard.
Your head is kind of, oops, sorry. Your head is leaning this way. And you've got category 1.
Really?
Yeah, you got a cat. So, but you probably had all that treatment recently,
Yeah.
right?
Last time.
Okay.
Not
So, hang on to that. I'm not sure. I mean, because I'm sure you've had your neck adjusted a lot,
Oh, yeah.
right? So maybe there's something else that could be, that we could do. I want to,
Dr. Downey, before we move on, can you explain like how we go about the range of motion, like what you're looking for based on the different positions? Are you like relining the vertebrae?
yes, a lot of it is kind of, I guess you could break it down in kind of about 3 stages. First, I just kind of feel. I just want to feel kind of the lay of the neck. I feel for tight areas, just kind of light palpation. And then I will push into the deeper muscles. And then I start moving the neck. And I move the neck and I feel for the tension in the muscles to kind of maybe equalize. It's something you got to just kind of play with. It's like motion palpation, if you guys had training in that. You're basically just, first you're just palpating the soft tissues, and then you just start moving, the parts and feeling for where the spring is. And with her neck, there was definitely, there was several different vertebrae that were kind of not sure which way they wanted to go. They're like, instead of just kind of a normal flow, which is, the neck is really designed to be kind of, all the vertebrae are kind of working together.
So to finish that thought, so you're not necessarily looking at the vertebrae, you're looking at the
Both. The muscles first, and then of course, that relationship to how the bones are the muscles, of course, are what are moving the bones or allowing the bones to move.
And then once you get her in that position where you find that her strength was the best, is that how you go about adjusting?
Yeah. And that also, if there's other things I want to test, that makes her nervous system sort of at its current base level. It's like it's most calibrated level, even though she's contorted. It's kind of it's something. That's my approach to it, and I do that on everybody. Everybody that where I find something like that, I will contort them to find where their optimal is. That's sort of, you can overlay it late. I mean, you don't have to do that, but I would advise honing that ability, because about 20, probably 30% of patients are regular approach with AK too well. Because there's these complicating factors like switching. And this, in my thinking, is a form of switching. It's another kind of switching. neurological disorganization, which is a more active.
So then would you go adjust for C2 when you first?
I probably wouldn't first because her C2 is, I mean, it's going out all the time because she has a lot of muscular attachment there that's trying to keep her head happy. And I would probably, using a lot of traction, start to get the lower cervicals to kind of open up a bit. And then treat the muscles that attach to C2. Upper trap, and, not so much, but, levator is a big one. Levator is like the upper trap. It's like the sibling that tries to always make dysfunctional family, function. Upper trap. Oh, I'll take care of it. Or the levator. No, we'll stabilize it.
The peacekeeper.
What's that?
The peacekeeper.
The peacekeeper. Yeah. So hopefully that answers your question. This is nuancing. You learn how to do. You look at your global range of motion, and then you do your palpation, and then basically you combine range of motion and palpation, which is what's ocean palpation. So that's kind of the way I approach it. And of course, you're monitoring how the patient's feeling too as you're palpating. But you can learn a lot from just seeing what the body is able to do before trying to make it do something. Anyway, any other questions on cervical disc while we're here? Oh, yes, I'm sorry, you had one.
So the head distortion, like where they want it, is telling you what muscles to treat and what the vertebra do?
Well, it gives me some indication. A lot of times, okay, you start testing and people have, like with these kind of things, you're going to have a weak tricep. The weak triceps is good because it's an easy one to monitor. And it's really sensitive to interiorities first. And so does the wrist extension and finger extension. Because those are all lower brachial plexus. So specific muscles, yeah. So I know what muscles are there, so I'm going to test the one, like the scalenes. Scalenes are almost always involved. And usually you have to go in and kind of reset them. A little spindle work, a little bit of open eye a lot of times. That's really common especially if a person's had a whiplash type injury. Those scalenes have taken a real beating. And sometimes the SCM as well, but a lot of times the SCM has been overworking to compensate for the injured, weak scalenes. Remember, there's a muscle called the longus colli, longus capitis. This is a small muscle goes up front, way deep, and those are often, almost always injured in a whiplash injury, and they're often just ignored because they're so deep and they're hard to test for. I can show you guys how to test for the longus capitis and colli. Anyway, does that answer your question? This is something, if you like doing physical medicine and you get good at it, this is stuff you're going to do every other day. You're going to find these very effective. You learn how to use like these basic AK protocols to dial in your adjusting or your treatment. You're going to do really well. Some people with mild and non-surgical herniations, they respond really well to traditional dynamic adjusting. Some people don't. Some people really only need traction. They need general respiratory moves, but you don't know that until you've tested their body to see what their body. And sometimes you got to experiment. What did we learn last session? We learned about ligament stretch syndrome. That last session, the adrenal-related ligament stretch. Okay. Looking to see, does everybody remember? You take any muscle, any ligament in the body, you give it a stretch, and you test a previously strong muscle, and it'll globally weaken a person. And if they have that, do not want to rush in and start doing a lot of loud dynamic adjusting on those people because their ligaments are like super sensitive.
But if they're normal and don't have road concerns, they shouldn't go.
If they what?
If they don't have, like, if they're normal, they should not go.
They won't be, right, exactly. They'll handle the stress just fine. I mean, you can stretch them and poke them. Kind of, you think of the body's range of tolerance for stimuli before it reacts negatively. You know, some days it's really wide, and they can tolerate all kinds of bumps and bruises and temperature changes and you name it, and you're fine. You're just fine. But then sometimes that margin of what the body can tolerate narrows way down, and then you're bouncing into a situation where the body's stressed and it starts reacting to stress instead of just reacting to the. So it's a lot of it, and what we're doing with, you know, structurally, nutritionally, and chemically, and emotionally, is we're trying to restore as much as we can that wide range of tolerance. You can tolerate electromagnetic frequencies and that. So, and that's kind of a big general idea that I kind of work off of. Anyway, you guys can read through these. This is just kind of goes over the. Well, I'm going to try. I never used this one. I forgot about this one. I never used this, but Dr. Tim used to talk about there'll be gastroc devious. The one on the side of the disc will be super tender. I'll tell you what I do see a lot, which kind of might go along with that, is a lot of times I'll see a category 2 on one side causing a functional short leg, causing pelvic sway, and then I'll see a brachial plexus issue, usually with either a lateral, anterior, lower cervical. That'll be all one package, and there'll be a shoulder like this, and there'll be and they'll have the weak tricep, they'll have all the stuff, and it'll TL to the SI. Cat 2 is like the sort of old instigator behind it. Clear the Cat 2, a lot of times all of the other stuff goes away. Or at least for now, until the Cat 2 comes back. So you've got to really focus on fixing their Cat 2, which means looking at their feet and looking at their arches. Anyway, this will be on your test. Anterior cervical or cervical discs will only TL anterior. I think it's on your test. Could be on your test. Probably is on your test. Questions like that. The nutrition for is manganese. Dr. Wally is big on manganese for any kind of like disc connecting tissue. Linkoplex 1 and 2 from standard. Those of you who work use standard. You're standard rep, right? Use standard. Yeah, so you're familiar with it. Linkoplex 1 and 2 are really, they're very powerful. So I threw these in. This is kind of all review, but, well, actually this is, but, okay, so. Okay, so this is just, this is really just maybe expanding a little bit on what we've been talking about with challenge. So you can challenge anything. When we're doing, if I am finding these weak muscles in the neck, for example, like we just did, this is the challenge. Having the neck in a different position is a challenge. It's a static challenge, patient-induced, if you will. You can challenge any suture in the cranium. You can challenge any joint in the body. You can challenge ligaments. You can get on the ligament. You can press it one way or another, and it will often give a change in muscle response. Scars will therapy localize if they're creating neurological noise. And that's a lot of, like, when we talk about stress receptors, a lot of times that those are found when there was a previous injury. But, then of course, visceral stuff, we talked about ICV, we haven't talked about stomach yet, right? The ICV is a huge player with the viscera, but there's all kinds of other visceral issues. Some of you have taken visceral. Okay. What style was it, the Moreau stuff?
I just did a shortened intro class to an instructor
Okay.
because I couldn't miss like
Oh,
so, but I
Good.
have it set up to take.
it's good stuff. Yeah. I didn't really start doing visceral work until, gosh, years in practice. Didn't do anything until I did, and then I kind of got really into it for a while. Anyway, so gait, putting a person in a gait or a certain position, plus all of those are challenges. Basically, static challenges. So anyway, just to kind of go, we haven't done endurance stuff yet, but like any osseous challenge, whether it's dynamic or static. Later, I think session 6 or 7, we do an anaerobic aerobic challenge, which is kind of interesting. Anyway, of course, mental, have people visualize things, affirmations, all kinds of things that bring up conscious challenges, scary thoughts, pleasant thoughts, all those things are a way of challenging the system. Then, of course, chemical, food, antigens, drugs, you can test all that stuff by introducing it either to the body's sensory system through the nose or mouth or electromagnetic, which if on your test they ask you anything about nutritional testing, because I didn't used to say this because I used to try to be more curious, but the official answers to any questions about nutritional testing in AK is going to be olfactory or gustatory or salivary. Lingual, sorry, either lingual or olfactory. Energetic testing is done by everybody in the AK, but yet the official stance is that it's not as accurate or as actual direct receptor challenge, which is what you're doing. Smell it. There's tons of arguments on both sides, and honestly, I find taste or olfactory testing things, especially taste testing, very difficult. I don't feel it's one bit because it uses the nervous system. I abandoned it years ago. It just drove me crazy. The only kind of testing I do now is I do it blind as well as I can, and I use the magnet. I use energetic testing, and it's that's not official stance by the ICK. So on your test, it's going to have there'll be a question every time. There's a question or two on the. So what I say, not what I do. And it's one of those interesting things in the AK world. It's like everybody tests energetically, but yet they all officially kind of reject it as being valid. It's kind of weird. I guess that's how, But the thing about energetic testing is especially if you're doing it blind, is you are the only factors you're really looking at are the energetic relationship between that substance and the person's aura. If I don't know what it is and the patient doesn't know what it is, then and you test it enough times and it comes up to like somebody yesterday that came up like 3 times in a row, the same. I kept retesting, trying to fool myself, and it was the same 2 things. Who is that? Who's that that retested? She's not here this morning. Anyway, we set those aside so we can test them. So just remember that for your test. Any questions on challenge? I mean, we first introduced it as like just vertebral challenge and whatnot, but it's the term is you know, be used for all kinds of ways of provoking the nervous system. So there's two ways of using. You're going to need a battery or something. There's two ways to approach it. You can start with a weak muscle. You can start with a strong muscle. I think it's best with any situation to find out what's strong and what's weak. That way you can test if you find something that turns on the weak muscle. It's coming from a weak muscle, problem focused. Then you verify that same thing, challenge or TL, both should weaken a strong indicator. Then you really know you got something. So just like with the vertebral challenge, you got a weak hamstring that turns on when you TL L4. And so you go in and you challenge L4 and you find out which direction it needs to go. And you go to a strong indicator muscle, say the piriformis on the other side, and you TL L4. So now you know you got it. Then you challenge it, and the challenge should weaken the strong indicator muscle. And then if you can, a lot of times it'll test it that way. A lot of times it'll go back and strengthen the weak original muscle. And then you really know you got it. So that's how you find your vector for adjusting. Otherwise, you're just sort of using your palpation skills and your imagination. But if you're using muscle testing, you can dial in adjusting way more accurately. It's just like I'm on an infomercial speaking. Okay, so this is, we talked about these, this is just, I think this is my last slide here, actually. So did anybody have weak hallucis extensors yesterday? Extensor hallucis longus or brevis? Yours was weak?
I wasn't here too, but I think.
Oh, you weren't here. Were you here yesterday at all? No. Oh, okay. Well, welcome back. Yeah. I thought, okay. Let's see. Let's just see. Some serious footwear. Your feet are well protected. Go ahead and lay them. So, how would I test your extensor hallucis? Upper foot. Extend her proximal. There. Okay. Now I'm going to hold the proximal and I'm going to test the distal. I'm just feeling for any kind of obvious trigger points because that one's a little again. So the distal, the longest, and the proximal is the brevis. So proximals, they're both pretty good, but the distal is a little bit iffy. Now bring this one up here and hold. So the proximal is a little bit spongy, and then hold the distal. So proximal. Have you ever injured this foot?
Not that
Okay.
I guess I've slightly rolled.
Okay. So we had a picture back here of that pain. And it's kind of right in the middle of the top of the arch. You'll find a hot spot. So I'm going to just do a little muscle spindle on that, see if that makes a difference. We'll start simplest thing, hold. And that is actually a little better. Doesn't really hold. Okay, so I'm going to go to the O and I of the muscle. Now this one, remember, this muscle kind of goes up to the towards the middle of the foot. Its angle, its pull is kind of not just straight up this way. It's more medial to lateral. Okay, this so far. Now this is where a lot of times you'll find, like she has a second cuneiform, this kind of jam. Now the cuneiforms, if you guys are, I don't know, they glide up, they normally glide up against the navicular. But if they get stuck up there, then you got a problem. They'll get stuck up there a lot of times because that's what happens when the foot takes a force and donates and collapses. I'm going to adjust this a little bit, okay? Just a little, I'm just going to give it a little nudge. Oh, there we go. There we go. Okay, so hold that right.
High heels.
What's that?
Like wearing high heels.
What do I think of it?
Could high heels.
Oh gosh.
Push up.
Oh yeah, yeah. It's one of the most common. Yeah, yeah. And cowboy boots and pointy. Yeah. Don't get me started. Hold that right there. Oh, there we go. Feel that?
Yeah.
Way big difference. Yeah. Now that's a little muscle there, but that can make a difference of how with her gait. We should have tested your gait first, but now hold the extensors. Good. And then grip my hand. Good. Okay. So what the other one we learned, the other two muscles we learned the flexor hallucis. I'm trying hallucis out today. Flexor hallucis longus and brevis. So with the proximal, hold that right there. With the proximal, oh shut up. With the proximal, I wonder what made her think I needed her help. Hold that right there. So I'm testing the brevis, and then I'm testing the longus. Hold there. Now, what's interesting is since the longus starts up here and the brevis is here, how does the longus get farther down the toe? The brevis actually splits into two heads, and the longest tendon goes between them. Remember, anatomical features. And so, a lot of times when you have a weakness of the brevis, now you've got the longus still attaching to the end of the distal segment, and you end up with a hammer toe. And so a lot of times when that happens, and I see this all the time, the arch is collapsing from years of weak tip posterior. Now you've got compartment syndrome. You've got tarsal tunnel syndrome, which is shutting down the nerve supply to the brevis. So now the brevis is atrophying, and it's not managing this proximal segment. Does that make sense? That's what causes hammer toes. And often you'll get a hammer toe, and then you'll get a hallux valgus, where you get bunions. So you'll get the big toe drifting off to the side because you've lost the lateral or the medial stability of that brevis, flexor hallucis brevis. That's a lot of what keeps this toe in position. So there's a whole sort of incremental evolution that leads to hammer toes, and thank you very much for bringing that in. Good example. And you'll see patients in various stages of this process. And like you have the picture yesterday of your patient. That's like, I think, too far gone to fix, but somewhere along the way in that patient's life, she probably had fairly normal toes that were starting to do that and intervened at that point. Anyway, so hallucis limitus is when the extensor muscles can't lift the big toe. And it's different than drop foot, but what it does is it causes people they end up, instead of walking this way, which everyone should walk that way, right? Instead of walking this way, where there's this kind of toe off thing happening, they are coming forward, lifting off. And if their body matches that, usually both feet are doing it, and they're walking like this without any toe off. But basically, it's controlled falling. That's how a lot of people walk. But what that hallucis extensor does is it draws the big toe up, and it also helps activate the tib anterior. All these muscles kind of work as a chain, and that brings the foot into a good position where then it can spring back and be erect. So it sets the strength of the ankle to rebound into a leg. So that part of gait is affected by just that one little muscle. If it's weak, yes.
Could you strengthen it just with like?
Well, theoretically you can. I mean, if you consciously lift your toes, that's why I like that heel raise exercise where you come up and you stop and then you come down slow. That gets all those intrinsic muscles to work. It makes that flexor and extensor brevis, they kind of have to work in a position. Now, if you do this, listen, they don't have to kick in. But if you come up slow and you hold until things stabilize, and then you come down slow, especially coming down slow, then you're going to get at those muscles. That's why I like that exercise so much. This won't do it. All day long, people can do their heel raises, and that will certainly strengthen their gastrocs and whatnot, but it won't fix these intrinsics the same way. So, the like feet learn this stuff really well. I wanted to go back just briefly. That picture. I had a picture of the. No, I had a slide with the all the different bones of the foot. You guys want to review those? Or are you pretty good? Remember how the bones line up with the feet? 26 bones per foot. Busy place. We can go back to that. Maybe we have more time later. I'd like to have everybody. I want to check everybody's muscle testing today, if possible, just to kind of see where we're at near the end of the session forward. So it'll be kind of like a mini. Down in your slide set. Come on, baby. Come on. Here we are. Here we are. Thanks, Dean. Anyway, just a quick review. You got these, the most common bones I adjust in the feet are usually the first and second cuneiform, sometimes the third. I adjust the talus a lot, navicular some. I find that more often, a lot of times I think when people are talking about adjusting the navicular, they're actually adjusting the cuneiforms. The navicular is harder to move than you might think. And I do naviculars prone. Cuboid is interesting. A lot of times there's cuboid will get kind of jammed medial, especially if the person's running or walking on the outside of their foot a lot. So you see what a prominent position that cuboid takes on the bottom of the foot. That's what you're bearing weight there. The test we use in AK, I don't want to get that slide up. Somebody come up here that maybe has had foot problems at some point? Just to prevent having foot problems. Anyone with feet? You want to come back together? Since you're all warmed up.
I wear platforms.
Do you? Why? Just you like being up high.
I like it.
You like the altitude.
I like
Yeah. Well, I was mentioning yesterday, I have patients who, they won't wear their platforms or high heels into my office anymore because they don't want to be. So they will come in sneakers or, flats. Because I used to think they quit wearing them on my advice, and then I've had this one patient say, no, I just never wear them in here. So, since you were here yesterday, hold that down and in. This is what muscle? What muscle am I testing? I'm going to pull you down.
Posterior.
Posterior tibia.
There we go. Which muscle am I testing? I couldn't figure it. Tib posterior, right. Hold. Good. That's a good one. Which muscle am I testing? Bring your foot towards the
Tib
flex.
anterior.
Curl your toes. Tib anterior. See my vector? Hold. It's a little mushy. Hold there. Yeah, that one's weak. Okay. Okay, now curl the toes down again. So we curl the toes down on these two dorsiflex ones, right? My ankle comes way out here. Hold. Pronatus tertius. Great. Push down. And hold there. Pronatus longus and brevis. Now see my angle? This is good. This is even better. And this is even better yet. Hold. See where my elbow sets where my vector is. If I say it's nice to have a high-low table for these. So that's good. So we got a weak tib anterior. Let's see if we got one on this side. That would be weird. Take your hands off for a second. Sit there, bring it up, throw the toes down. Hold there. Yeah, you know what? That's interesting. Okay. Now, you wear platforms a lot, right? Mm-hmm. Okay. So I'm going to try something here. This is just a gastroc foot. I'm stretching pretty much everything. Now I want you to see if you can pull your toes away from mine. There you go. Good job. While you do that, I'm adding a little more stretch. Now pull your toes away from my hand. Basically a PNF, stretching for the gastroc and feet. Go ahead. I didn't do the preliminary traction. We're going to push into my hand. Remember, PNF, you have them hold for 4 to 6 seconds, and then you have them pull away. That way you're stretching the muscle mechanically, and you're also helping to turn down the tension in the muscle neurologically. Pull away from my hand. Good. Now pull away from it. There you go. Now let it relax. Felt that? Yeah, it really stretched. So basically she's been wearing those shoes. So it was she was having trouble getting into dorsiflexion. Now hold there again. Curl the toes down. Hold there. See, that's all day. So her tib anteriors were turned down because they've been put in a stretch position, and then the gastrocs haven't been stretching enough. So they're not getting the right inhibitory signals. The gastrocs aren't getting the right inhibitory signals. Tib anterior muscles aren't getting the right facilitatory signals. So that was a simple fix. Now, you could do downward dog if you spend a day wearing those things and you get home, do a downward dog for some semblance of that to reset your gastroc and your flexor digitorum group. So,
Dr. Diamond, what's PNF?
proprioceptive neurofacilitation, also known as PNF. And I'm sorry, anyone else never heard of PNF? Maybe it's an old term. I don't know. You've never heard of it? Good. Somebody come up here with tight muscles. What's that?
Which group of muscles?
Hamstrings are easy, hamstrings? Are you a hamstring guy?
I don't know.
Okay. Yeah, let's have you lean back. So, actually, I don't know.
Never mind.
I'm being hustled. No, let's see. Somebody's got to have tight hamstrings. Steve? I want to show you PNF on tight hamstrings. It works like a charm. Like a charm. So this, I don't know, I learned about this years ago. I don't remember. I think I learned about it from somebody who was like a sports person, a massage person. So he's a little tight right there. So when you find that, and actually that's a little more yielding. Ooh, yeah, look at that. Ooh, okay. Turn your head to the left. Yeah. Okay, well, we can't get into that right now. Sorry. Okay, so what you do with PNF, come up where you feel the first resistance, and I use my shoulder, and especially if I got a strong patient, push into my shoulder. And as they do, I just resist. And their hamstrings are contracting. Now, okay, make sure they're not hurting or anything. Now I want you to contract these muscles, and I want you to lift away from my shoulder. And I just follow him. He's using his quads to stretch his hamstrings. Now push back again. So that's the first bite. Take one good bite. There we go. Now if it's a little uncomfortable there. Yeah. So you're contracting the muscle in a lengthened state. Now contract your quads, pull away from my shoulder. Look at that. Now push back again. Now pull it one more time away from my shoulder. Look at that. Voila. And then I see he went from whatever that was to there or so to this. That didn't take me long. That's a beautiful technique. It's very simple. And it's also a good way, patients love it too, because they have it. They say, oh, I've got tight hamstrings. And then if you're able to unlock them like that, they're like, I've never seen them stretch that far before. So then it's a good confidence building tactic, I guess. Push into my shoulder. You're not as tight on this side. Push and hold about 6 seconds. Yeah, work on this side too. Take them both to the gym. I have the favorite leg. Now pull away from my shoulder. So I'm just lightly following him and making sure he doesn't bend his knee because he'll want to. Push back again. Push, push. Sometimes I can get a good stretch in my calf while I'm holding. Now contract your quad, come away. There you go. There we go. Look at that. Push one more time. Hold. Make sure you're breathing. Now, last time, pull away. So that's PNF. Thanks for asking. Anyone else not familiar with that? You were. You can do that on any muscle. Any muscle. But, look at that. And what's interesting, I find a lot of times, is I'll do both sides will be super tight. I'll do one side, and then the other one's already starting to let go. It's like it knows what's coming. You still got it. Okay. PNF. When we talked about the triad of sprain strain, you have the primary weak muscle that's been injured. You've got the tight antagonist that we use special flush on, weakens after is strong in the clear, weakens after a stretch. Then you've got the synergist that responds to strain, counter strain, and also that's often your reactive muscle, like we talked about yesterday. So in addition to fascial flush for the hypertonic antagonist in the triad of sprain strain, you can use PNF. I find it to be equally as effective as fascial flush and often more, and sometimes I do both. Depends on if the muscle really feels fascially congested, I'll do that too. But PNF really changes the tone set and the length of that muscle very, very effectively. Trainers use it a lot in sports. It's just a brilliant technique. It's simple, it's safe, doesn't require a ton of skill to do. Anyway, so this is something you can take with you, laminate, print it, laminate it, have it in your collection of quick grab notes. There, between different AP people over the years, they seem to find this correlation between certain kinds of foot subluxation. Gastroc, that's a good go-to. I use that all the time. We did the gastroc test. If somebody's weak with the gastroc, the first thing I do is I challenge the callus and the calcaneus. A lot of times there'll be something in there that I need to do a correction on. And I don't usually pop those. I do like the respiratory. Popliteus, a lot of times you'll see laterally rotated rear foot, calcaneus. Lateral cuboid, TFL, so on and so forth. Try these, like when you're workshopping, like an AK club, maybe take this and just go through and if you have a week, let's try it on somebody. Somebody come up that has a couple feet that haven't worked on. Let's just see if any of this stuff is true. Do you have any foot issues? Sprains?
I broke the left.
But in general, feet. We know you're not like hurting. So you may or may not find. So let's start with so lateral cuboid. Honestly, I don't find lateral cuboids too often. I find medial ones a lot. Push up and out. Whew. Let's try it on this side. Push up. That one's strong. So if it's a lateral cuboid, I'm going to press it in, sort of in towards the midline. Challenge it. Up and out. And look at that. We got lucky. So that's true. Okay. I expected we'd have to do a medial cuboid. Posterior tip. Okay. Let's tap there, running down this way a little bit. Now down and in, hold there. Hold. No, that's pretty good. Let's try the other side. Down and in. Hold. Oh, that was a little mushy. That's not bad. That's not good enough to chase after. Okay, so PMC, pectoralis major clavicular. Hold there. Go down the list here. Medial acute adductor. Hold there. Push in. Woo. Try this side. Push in. Ooh. So interesting. Okay, so it says medial cuboid. Let's see if that. Let's challenge this. Push in. And that. So I went lateral. Let's see. Let's go. We went medial on this, and it. So that holds through. Now, these could be temporary fixes, obviously, but the relationships seem to hold. Supraspinatus. Now, if they're not weak, obviously, you don't go to the foot, the associated foot bone. Anterior tib. And bring this up, anterior tib. Up, there you go. That's strong. Medius. Push out. Okay. And push out. Yeah, so on the left side, so glute med is going to be supposedly laterally rotated metatarsals. When I find that, usually what I do is I just kind of I traction them, and I just kind of do like a spiral. So like that. And push out. And that turns that on. But we're going to go, and I had skipped over this slide, I think a couple times. The shock absorber test is how we screen for foot bones. Is you bang on the foot. I did it yesterday. We didn't really talk about it. And then you test strong indicator muscle. Now that muscle was weak in the clear. Let's try this. We knew this one was strong originally. This, in a crude way, simulates that. So that tells you, well, there's something in the feet we need to look at. The shock absorber test is how you enter into the, or how you can enter into the foot evaluation maze. So hernias tertius, this is the last one. See that I missed? Oh, we'll check for gastro. Pull that right there and curl the toes down. Hold it. What am I testing? Tertius. See my elbow? And that's actually weak. Sorry. Bring this up here, curl the toes down. There you go. Hold there. Now, both of those are weak. Okay, fifth. So what kind of shoes do you wear? You wear good shoes. But you wear good shoes all the time? Yes. Now, who had the, Elle, do you have your activator? Can I borrow it? So I'm going to adjust her fifth metatarsals with activator. In my office, I would use arthrostat. Same idea. So how do I adjust the fifth metatarsal? Well, shall back on now. Let's go back to this one. We know we can trust that. So I'm going to go to the fifth metatarsal and I'm going to press it up this way. It's fine with that. I'm going to pull it down. Not so much. Okay, so it needs to go. It needs to go up. So it needs to kind of. It really needs to be just kind of pushed back in here. So what I'm going to do is I'm just going to press it back in there, and then I'm going to hit it with the activator. I'm basically pressing the bone joint into the motion or the stable position that I want, then hitting it with this sends a burst of stimulus into the joint capsule. Receptors. So, pull it down again. We had to do both of them, didn't we? Shout. Up and out. That was gonna push it superior. It wants to go down. Okay. So same thing. It's interesting. So I would. You're fairly narrow feet. You probably could wear a lot of different shoes, right? You don't have trouble with width, probably. Pull that metatarsal. Give it a. Hernias tertius. Up, curl the toes down. Hold there. Okay, good. Curl the toes down. Good. Okay. So that all. Hopefully that tried to run through that as quick as we could, but thank you. Walk around a little bit and see if your feet feel any better.
I think so, or they feel the same.
No worse. As long as they're not any worse.
No.
So, anyway, that's a little cheat sheet you can use when you're looking for stuff to adjust. You know, instead of you kind of go at it like say you're evaluating a supraspinatus or serratus or some shoulder-related muscle, and you're treating a shoulder problem, and then you get it all done, but then next time they come back, one of the muscles. Well, you might want to check the foot, in addition to doing the other stuff. You get done with that, and then just double check the foot. If the muscle's strong, then you just challenge different bones of the foot that you know are associated with it, and you'll often find a sort of underlying problem. The most common things I see in feet: first, second cuneiform, jam, sort of superior. I see that a lot. Lateral talus a lot. I see lateral and anterior taluses a lot. I treat a lot of those, adjust a lot of those. The other stuff, kind of smatterings here and there. Taping, I don't know, it's a big subject. Honestly, I use almost no taping. I do use kinesio tape now. I was one of those that, like, when kinesio tape first came out, I just tape, overpriced tape. A big deal. A different color for kinesio. I was just this curmudgeon guy, and then one of my friends and colleagues treated me for plantar fasciitis about 10 years ago, and he did a bunch of adjusting on my foot. Then he did all this kinesio taping on, whatever. It was amazing. It helped me so much. He got me out of that problem, lickety split, and then I started using kinesio tape and kind of learning. And when I did an Alps trip about 3 years ago, it was a group of 5 of us, and my buddy who set the trip up, he is also a patient of mine. He had a knee problem. We did this 110-mile hike, and I treated him about every other day. Treated his knee, and then I brought kinesio tape with me, and we just taped him up, and he was fine. He got through the whole trip. It was amazing. So I have a whole new respect for kinesio tape, and what do they say? I had to eat some crow. Because for years we had elasticon, which is good stuff, but none of that stuff works the same way kinesio tape. I don't know what the heck? The way it stimulates the skin receptors, and the way because it's very thin. You guys familiar with kinesio tape? Everybody is. It's just, but it works really well, and people can wear it for 3-4 days. You can shower with it. So I do use it on certain things. Usually knees, a lot of times. Knees, a lot of lateral ankle stuff. I'll do it, and I'll have the patient take a picture with their phone, and then they can do it properly. Anyway, this is something Dr. Lee used to say when he thought people needed orthotics is when you had all of these tender areas on one side of the body. Basically, he would say that is the kinetic chain result of a collapsed arch, of an improperly functioning arch. You guys probably all know if the arch collapses, then the knee is kind of forced medially. The tibia is externally rotated, which puts more strain on the medial meniscus, medial collateral. And then, of course, you've got piriformis up here trying to control that internal rotation of the hip. And then pretty soon it works its way all the way up into the shoulder. A lot of times a category 2 is like that too. There'll be a category 2 pelvis which will show up, but really it has all these other components. And hence, of course, with a PI cat too, you have the medial knee tendinosis as one of the diagnosing factors. So this is something. I don't use orthotics anymore. I used to make them in my office, different kinds. long time. When I went cash years ago, I kind of, I mean, every once in a while, I'll use the orthoplast, the ones you can get, they're like have a resin. But we've got a podiatrist next to us. And, you know, he takes every kind of insurance you can name, does a great job. So they really need orthotics.
Dr. Downey,
Yeah.
the lateral, I can't wrap my head around that. How does it?
The when you have a collapse of the arch, the tibia rotates internally. It kind of tries to rock the talus medially, and then the calcaneus gets torqued where the talus and calcaneus come together. And it kind of on the outside. If you were inverting the other way, it'd be more. You'd probably end up with medial pallor and particular pain. But yeah, those bones approximate, basically jam into one. That makes sense. Pterygoid pocket, of course, is one of the things we monitor with TMJ stuff. But yeah, so when you find a category 2, check for everything north and south of that pelvis. As you're learning, I mean, we'll go into knee, I think there's 2 sessions now. This is session 4. We got 3 more. So we'll do shoulder next time, TMJ, acupuncture. Then session 6 will be more acupuncture, more TMJ, knee. I think that's how it goes. You should remember, heel lifts, never use it. Never use it. I don't know where my box of heel lifts is right now. There's some cupboard. Somebody has a damaged leg that's shortened their tibia or femur, and their leg length difference is more than, say, a centimeter, then certainly they need it. What they need is they need to build up shoe. And I have some patients that have, from a very young age, something, hip dysplasia, a lot of times they'll end up with a really short leg, and they have to have a heel. But as far as heel lifts for anything under a centimeter, forget it. You know, so patients come in a lot of times with heel lifts from their chiropractor or PT. I'm like, then I adjust their pelvis and their legs are that even. I'm like, you don't need a heel lift. Sometimes they don't believe it, but they've had it for years. And so I have to give them my whole song and dance. But usually I can get them out of heels if they've been in it. So that's probably, most of the heel lifts in my box are probably old heel. But I do have heel lifts, this box of them, those ugly little brown ones I've had for years. Any of you guys runners, or like have a history of serious running over the years? So obviously this the heels, a normal pattern of wear is maybe slightly more on the outside of the heel coming through. That's actually a pretty normal pattern of wear. When you see excessive outer heel wear and excessive medial forefoot wear on the shoe, obviously they're not tracking as well as they could be. What's interesting to me is when you see normal wear on one shoe and really almost the opposite pattern on the other side. Those people, well, you see, you know, like they're supinating on one side and pronating on the other, and they can be tricky. So if you get a chance to look at your patient's shoes, they wear older shoes in, you can learn a lot. I've had patients that are runners. They'll have $1,000, and I'm not exaggerating, worth of running shoes that they've been trying. They bring them all in, and I will adjust them, and I'll test their scalenes and SCM and different stabilizing muscles, and I'll have them put each pair on, and we retest them. And a lot of times I can find out which pair A lot of them, a lot of their shoes are weakening. Put them on, they stand there, their scalings just go. So that's kind of fun to do. It's kind of interesting, but it's sad because they got all these really nice shoes that you donate. But it's, to me, it's like, how could you buy a pair of shoes and not get muscle tested? But I know I live in a strange reality, but I would dream of, you know, if I like when I bought those shoes, Jane was with me and I walked around with them and she muscle tested me several different ways. And I had a couple other pairs that I weakened on. Like, I even muscle test on the color. So, but like I say, I live in a most AKers get to know them. Some of them are way crazier than others. Ligaments, I don't really use this much, but this is something you want to know about for your test. And some people claim it's very effective. When you have chronically tender ligament areas, like you often will with a knee or an ankle, there's often this kind of locked-in pain pattern with the opposite corresponding joint. So the joints that correspond would be, you know, and this has to do with the gait, would be shoulder, hip, and as you go out into the skeleton, elbow, opposite knee, so on and so forth. Sternum and, you know, one side of sternum and the other side of the sacrum, for example. TMJ can have a ligament relationship to pretty much anywhere. Xiphoid coccyx, so on and so forth. I have done this with elbow and knee at times. And so here's the protocol. Ligaments pain persists. You get it all done and they go, yeah, you know, it still hurts. And, you know, you're already behind. You say, well, you know, I don't know, did you get all that? It still hurts. This can be a good technique for those patients. So does anybody have a tender shoulder or hip or knee? I can kind of talk through this while we demo it. So it's kind of tricky because you need a two-handed TL. Let me have you lay on your back. So where are you? Right hip. Okay. Right hip is tender. So can I palpate it? So right hip, right there. So right over the trochanter. So of course, the trochanter isn't a ligament. I mean, you got the trochanteric bursa there, and tender there. So back more towards like where the insertion of the piriformis is. That's your TFL right there. So it's hard to get at the ligaments in the hip, but let's go to the opposite side, shoulder, and see if you have. There, that's tender. Now, is that more tender
Then my hip.
than your hip?
No, my
Hip's more tender.
I didn't know this was tender until you.
Right there.
Yeah.
Yeah, okay. So I'm going to get a strong indicator muscle. We're going to see if we can therapy localize it. Now touch the hip. This is just a TL to that TL is that way. So there's something else that we need. So so we want to fix that first. I have a feeling that push up and out, push down and out. Move your hip around. That hurt.
Surgery.
You?
Yeah, I had surgery on my left.
Labial tear.
Yeah, I had a labral tear and I fractured my femoral head, and so it's a little deformed. It's
Great.
yeah.
Okay, so that makes sense. So I'm gonna put this.
Yeah, sorry.
Yeah, no, that's good. That's good. Yeah. They might have a wrist or shoulder. In the shoulder. It's hard. I always want to get at the ligaments, so I can. But I do. I am interested. Have you injured that shoulder? Yes. Tenderness there. Yeah. Right here. So he's got, yeah. Okay, so how about down there? That's actually. So I'm going to find a strong indicator muscle. I want you to touch here, touch. That where I'm and then hold there. So that's, it's a two-handed TL. Now, is this more tender? So I'm going to, quick and dirty way to do this is I'm going to manipulate, I'm going to hold both right there, ligaments, and I'm going to manipulate the least tender one. And Vaughn, is that going to just basically putting, loud afferent into the receptors down here. And not so loud nociception through the nociceptive receptors, nociceptors. So I'll give you a little bit more. So we'll go with that. 50% better, 60, 70, 70%. Okay, good. Yeah, yeah. 70% is pretty good. 80% is even better. 100%. You might have treated, you might have overtreated. They'll never come back. You have to leave them with a little something. Anyway, so it's a way to now we haven't done hyoid. We're going to learn hyoid with TMJ. And maybe we can revisit this because hyoid plays a big role in how these two areas are coordinated neurologically. Yeah. So, you know what? Does anybody have any skin scars that they're willing to share for the good of the group? Surgical scar?
Yeah.
Good one?
I had kidney surgery.
What's that?
I had kidney surgery.
Right, okay.
That's a few.
What's that?
I said that's a few people engaged in that.
What do you have? You have something?
On my neck. Oh, and on my ribs, they took out a rib.
Took out a rib.
Yeah, when I was 3.
You know what? You and her.
I mean, I should have wore a different shirt.
Now that's a good. These are good examples of what we want to use for IRT, which we haven't done yet. But oh right, that's right. Okay, so that's right. That's a deep one. What'd you have there?
I was bitten by a pit bull.
That's right. Okay, so she just TLs right on that. Now, is that vertebrae or is it the scar? I don't know. Could be both, but I'm going to have you touch just right on the scar very lightly. Usually that's, a enough to where you're not accessing the deeper structures. Now, she weakens with TL. Now, just traction the scar superior a little bit. Traction it down. So, so I want you to traction it down. Breathe in. Now, traction down. So you find the maximum weak. Now, sometimes they won't TL, and then you have the patient traction the scar, and then they'll show. That shows both ways. Breathe in. So I need to. What I'm going to do? Go ahead and let you. So what? No, it's fine. So what you do is you get on the scar and you stretch it towards where it causes weakness. On the phase of respiration that negated that weakness. We just did. So and it tested in both directions, and it negated by inspiration. So breathe in, and it's just like a cranial respiratory correction. I'm just tractioning the scar. Is that okay? And about 3 times that way, and then I'm going to traction the other way. Now, there's a lot of things you guys know about, different oils and stuff you can put on scars that will help them. Scars are kind of like, they can remodel over time, and sort of the fibers can kind of reorganize to where they're not triggering so many nociceptive receptors, stretch receptors in the skin. Now, that TL right off the bat, when TL it again, it's light doesn't now traction up, traction down. Take that away and then kind of move your hand forward. How old were you in this house? 2. Wow. I just moved it to kind of, now breathe in. Traction up, breathe in. Traction down. Oh, you were already in. Out. And in. So I didn't get enough of it. Sorry. Now I would probably use, I don't think I have it in my office. Wheat germ oil, of course, is a really good one on there. And kind of, as you're tractioning the scar, kind of work it into the tissue. There's all kinds of different things you can use to help you. But basically what you're doing is you're trying to clear out and disrupt some of the adhesive elements in the scar that are sending in bad neuroinfo. Right. Yeah, I just wanted to get it. Go ahead and TL again. If it doesn't TL in the clear, now traction. Good, and traction down. Good, okay. And were you breathing in or out? Were you just normal? So yeah, so that I took more than I thought it would. That's a big scar. And that might be something you maybe put some wheat germ or something, some kind of herbal oil. Yeah. Yeah. That's skin technique. You can, where that really comes in handy is when scars are in a location where they're interfering with a major meridian. I've seen some amazing things with people's pain patterns, but not just what I've done, but acupuncturists too. Sometimes they can really unlock pathways that have been blocked by a scar for a long time. I had this one patient, she had a brain tumor, benign brain tumor. And of course, they cut a chunk out of her skull and then removed it, and then they put back, I think they put the piece of skull back. It was just a mess there. It healed, but it was just numb and just all kinds of. And she started having all these right leg problems. knee would give out and these things. And I worked on her, and she had an acupuncturist that she ended up going to, who was able to clear that. I think it was probably the must have been the gallbladder really blocked. She was able to fix that, and she made a full recovery. It was amazing. I ended up getting to know the acupuncturist. I've referred several people to her since then. She's amazing. She's a medical doctor who went back and became an acupuncturist. So anyway, this is ligament treatment for the in the extremities. You're going across the body, shoulder, hip, elbow, knee. In the spine, you're basically treating the ligaments. So it's the same idea as a ligament relationship. So if you have tenderness at C5, you go to L1, and you find the interspinous ligaments that are one that's the most tender, and then you treat the most tender. Or you can just adjust the vertebrae. A lot of times that will clear it. Skin we just covered. Are we lost a half hour? Vitamin E oil. Oh gosh, I almost forgot this one. This is our last technique, and then we're going to back some more muscles. And I want to do something with cold TMJ, because TMJ's next session, but this might get you thinking a little bit. Hopefully. So Palo Alto is, and not to be confused with the equilibrium reflex technique that we talked about yesterday. This is another technique where we test two muscles at the same time. And this correlates to the feet. And not so much specific bones, but often a specific foot bone will be out, causing a disruption. This is more through the vertebrae. So P stands for posterior. You test the posterior muscles. We'll do this on somebody. Anterior is contralateral flexion. Lateral, you test together this way, obviously supine. Oblique is where you test gluteus medius, and opposite shoulder traction. And then adductors. So the P stands for posterior. The A is for the anterior. There's pictures of them here in a second. Lateral is the lateral. Oblique is this. And then drew a blank. So there's the posterior. That's SP3. A lot of times there'll be an issue with the great toe, or maybe the stuff we just worked on with the flexor hallucis brevis. And then this is number 2. This is A, anterior. So it's arm flexion and leg flexion tested together. 744 is going to be lateral, tested together. And then gallbladder 42 is for the oblique. So it's actually TFL and shoulder contraction, not glute. And then adduction is the last A, and it's bladder 65. So any of the metatarsal heads could be somehow compromised and cause a disruption of this acupuncture. Somebody that I haven't worked on somebody that I haven't worked on, if I can demonstrate, this is kind of fun. All of the treatment is at the feet. So now, excuse me. First, yeah. first we'll do posterior. And that's basically one arm extension and the opposite leg. Bend your elbow a little. There you go. So it's not like specific muscles so much. Hold that. That's good. Sit on this side and bring this side. Little pop there. That's pretty good. Okay, now lay on your back. So we got, push out for me. Make sure the individual muscles are strong by themselves. Push, push. Pretty good shape this morning. Yeah. I say these aren't real, they're not specific muscle tests, they're more movement tests. Now, let's test together. This one is the trickiest. The adductor up there, pull in. Good, okay. Then pull in. Didn't test these individually, but they're strong. Okay, now I'm going to have you take TFL. Good, TFL. Good. Now roll your right shoulder up towards you like you're coming into a half crunch. Ooh, a little harder, yeah. So there's one right there. So that's oblique, P-A-L-O. So that's over in here. So same thing over here, TFL by itself. Roll your left shoulder. That's good. So that was the week in there. So gallbladder 42. So I go to gallbladder 42. Is that tender? It is tender. So when you find that, then you check, is the metatarsal phalangeal joint okay? It seems to be okay. But it might be jammed. You can come up into the 5th metatarsal and see if there's, is that okay? And let's get in there. I'm just going to give that a little traction. There we go. So once again, TFL. Good. And roll your shoulder up. Yeah, see that cleared that. Okay, that's cool. Okay. And the last one, did we do that? We did that one. We didn't do that one. So abduction. And we did test the glute medius. So so good. And then out. So that doesn't show. And then the flexion. Did we do this one? We didn't do this one. Yes. So individually, and together. Yeah. Okay. I had to dig for it. So that would be liver 2, which is right here. Now, when you find that, then you check the first ray for any kind of issues. You go up into the first cuneiform, go up into the second cuneiform, that's navicular. Just kind of go in there. So you're really trying to treat the acupuncture point, but you're assuming that the acupuncture point is being impeded by, jamming and sort of disruption in the matrix, myofascial matrix that's interfering with the meridian. That's the way I see it. I'll let that go. So this here, yeah, that's way better. Okay, thank you. That was now. This, if you'd like to work with athletes, this is a great little finishing technique.
So are you applying pressure to the point as well as examining the joint?
If I don't find a specific thing me being a chiropractor, I'm always looking for something to yank and pop. But if I don't feel anything particularly out in the articulations, then I'll just push from. Or if you're an acupuncturist, that'd be needling. Or I use a little pen laser sometimes too. Yeah. Older people, kids that I don't want to be yanking on them too much, I'll use the laser. Which seems to work just as well as the pressure. But if they've got a little subluxation somewhere in the feet, you really want to fix it. Because it'll always be kind of creating some disruption with energy flows through there. Any questions on this? Did we do this last year? We didn't. Did we do this 3 years ago? Yeah. That seems like a long time ago. I think it was just yesterday, but it was 3 years ago. Well, this is first 100-hour course. I think, was that your first? Where do the years go? What's that? You were just a kid back then. So anyway, it's a great technique. Practice it. It gives you a roadmap when you're trying to figure out how to adjust the feet. I mean, otherwise you're like, oh, I want to adjust the feet. So you just start yanking. As you learn how to adjust different modes, you just start yanking on all of them. But this gives you a roadmap, gives you a recipe, which subluxations are worth treating. Anyway, that's. Oh, I forgot one. Oh my gosh. Oh, and this could be the most important one. What am I thinking? So this last one is for the kidney 1, which doesn't fall into the Palo Alto, shortened name. And basically, SOAS and basically PMS together. Let me do it one individually, but now together. Woo-hoo. Okay. Now, individually, SOAS is very good. Together, no way. Even though this one holds, this one. Okay. So, same thing here. Push, push. Okay. This one here. Good. Together. So, interestingly enough, you guys remember what fixation will cause a bilateral psoas weakness? Last session. CO, occipital. Usually a jammed inferior occipital will cause a bilateral psoas weakness. So when you see a bilateral psoas weakness, also check kidney 1. Kidney 1 is the sedation point. Sedation point of the kidney meridian. But in this particular protocol, it's what will normalize that muscle relationship. So I think, I forget when I brought this up. Maybe I talked about it when we were learning gait, but kidney 1 is a master acupuncture point, and it causes a general, downturn of energy in the kidney meridian momentarily. When we walk, as we plant and toe off, we're activating kidney 1, which I think is interesting. So as we activate kidney 1, which turns down the psoas meridian and turns down the kidney meridian and turns down the psoas tension, that allows us to toe off and move through it again. Because the psoas has to turn off to allow me to go into toe off. Sure, I wasn't overlateral problem. Yeah. So it's always seemed to me like that was by design. Activate that point and it turns it down and you're able to transfer across. Otherwise, you'd end up this. We'd walk like a bear. Okay, we get that one? No, it was this one. Yeah, this one. We didn't retest it. Oh, is this one? Yeah. Yeah, see? That's all we need. Oh, right. Thank you. That was my mind. Somebody's got to pay attention. So that's the one for kidney one. I use kidney one a lot when I have a hypertonic kidney because it's pretty hard to go in and actually flush the psoas, hypertonic psoas. So I will use kidney one to turn down the psoas, and I'll sometimes hold it for a while. Just hold it on the patient and keep retesting to make sure. Because when you have a normal psoas, and if you tap, just gently rub on kidney one, that psoas will turn on in normal circumstances. If it doesn't, then the psoas is hypertonic. So then you can use that as a way, and you're not going to normalize the pelvis and the low back and anything else until you get the psoas muscles to kind of work together. It's very important. You have to fix the weak one, of course, but you've got to address the tight one. And people are usually brought into your office from tight, painful muscles. They don't come in saying, I'm weak in my right QL. That's why I'm here. They come in because they have back pain. And something's tight. And so, tarsal tunnel, we talked about that yesterday. This is really important to know, to understand. This is that tarsal tunnel. A lot of these, well, okay, this is, I went too far. The nerve supply to the flexor longus is above the tarsal tunnel. So the tarsal tunnel can get collapsed and it doesn't affect that nerve supply. However, the nerve supply to the brevis be compromised. Brevis first doesn't fire right and then eventually atrophies. And then you've lost the integrity of that. You end up overly relying on the longus, and then you end up with the toe doubling back, and then pretty soon you go into lateral. That's how a lot of these foot problems. And then you add bad shoes to the mix, pointy shoes, and or heels where your feet are always kind of being, or you're always loading towards the front of the foot. And I know a lot of people explain to me if they're used to walking in heels, they bear weight on the heel. And I do believe that some people walk in heels really well. But a lot of times you see people in heels walking like this, especially you go to weddings or funerals, and you see women wearing heels where they never wear heels, but they wore heels for the, and they're all, it just cracks me up. So anyway, for men, put on their best cowboy boots. I'm terrible. I watch people walk all the time, and I'm probably kind of judgy. So anyway, tarsal tunnel, you'll see it a lot. Address all those muscles, and then work your way up. Fix the knee, fix the hip, fix the pelvis, fix the dural torque. So this is pretty much what we've learned. I mean, these are the things that we've learned so far. And this would be one way of doing your patient approach. Not the only way, but it's one way you can kind of start and start clearing the stuff like switching and whatnot, to where you can drill down into the central issues that the patient might have. Ocular lock is a really good kind of cheap way to get people unswitched. So if they're switched and they got positive K27 cross crawl issues, they come in talking about, and they think it's a different day. If they come in, sometimes people come in, they like, I'm like this sometimes. You don't finish your sentences, kind of jumping around. Check these people for switching. Everybody stand up, please. I'm trying to stop. So I want if you guys would indulge me, come down here. We're going to do a short little. This is as much for my own curiosity as anything. I taught yoga for years and years, and I would do this every time I had a new class for years. So we're gonna do a short little exercise here. First, I want those of you who've done yoga before, you're familiar with asana has a basic standing pose where you basically just stand there like the anatomical person, and you look for the weight in your heels. You can close your eyes if you want, or you look for the weight in the heels. You look for the weight in the forefeet, and you try to find weight balance on those 4 points. You open up the thoracic hinge, you let the chest open and spread, you let the head come back over the spine. And while we're here, we're going to take our awareness into our spinal column. And we're going to feel the difference between the spinal column on in-breath and out-breath. So as we breathe in nice and deep, using the inflation energy of the breath, we're going to relax the spinal column and hold the breath. And rely more on the inflating power of the breath. Now exhale. As you feel that deflation, I want you to tone up the spine as if there was an energy shooting right up through the spine, up the top of the head. Toning, narrowing, lengthening. And you breathe in again. Spine relax and let the lungs fill and the inflation happen. And then back the other way. So there's this interplay between inflating and supporting ourselves with the breath and letting the spine relax in between. And as the breath goes out, the spine tones and squeezes. That will actually enhance sacral function as well. Now, from that position, you guys are awesome. You all close your eyes. It's such good centering technique. So, without thinking, I want you to step forward on your right foot and stop. Please. Come back. Now, go ahead and let your arms relax. You want your arms and upper body into the, you're going to do like a animated step. We're going to step forward again and freeze. You should know what I'm looking for. So, guys, really, it's about, okay, so you stay where you're at. You stay where you're at. Stay where you're at. Okay, stay where you're at. Stay where you're at. Everybody else relax. So, L is stuck in home line. Right foot and right leg are forward. You're kind of there. You guys are kind of there. And I think like you're kind of, you just don't see this happening as dramatically. A little bit there, you guys can relax. And you're kind of, see, you're kind of following. Yeah, there you go. So, does this make sense? And you are in flow. So, this, and you are, now you're fixed. Now you're fixed. So everybody relax, and we're going to do the other side. Now that you know what I'm looking for, you're going to be more aware of it. Go ahead and without thinking, just step forward like you were going to step forward. Other leg. Now, go ahead. Now you know. Fix it. Yeah. Now, okay. We need to fix you. We need to fix L. Guys, good. Now we know. See, okay. So, at ease, everyone. So, two of you, once you knew what I was looking for, and you kind of like you raised in your consciousness. Several of you kind of, went into normal cross crawl, but two of you didn't. You And that's what I used to find in my class. I would find 2 out of 5 on average, people would do this. And maybe 2 to 3 out of 5 would do this. And then 1 or 2 of them would get it right away. Oh, okay. And then they would. But 1 out of 5 wouldn't really get it. 1 out of 5 would just like, that was, they would, those people were the ones that switched. So thank you for indulging me. But that, when I have a sample like this, it's to do that. That's been consistent for years. So if we're walking like this, we are not walking off. So check your guys. That, yeah, but you got the second time. You're like, oh yeah. So that you're like 1 or 2 of the 5. I don't mean to pick on you guys, but that is, now, we could spend more time on this, we won't right now, but we could spend more time and you could do a series of cross crawl, which would ultimately be what I would have you do that if we find it out. Cross crawl, a lot of times we'll turn on the right program. So, do we want to, it's 11:10. 11:10. It's 11 hours. Do we, that clock drives me crazy because it's 20 till, it's always 20 till 11. So do you guys want to, here's what my goal would be. I want to know where you guys are at. Some testing. I know you all know how to do these tests. Sometimes I still see you doing them in odd ways, and I want to make sure you're all doing them the way I want. Because I'm the one that does your practical exam, so you have to please me. But no, I want you to be doing them in the optimal way. Because there's a lot of different ways to set up test and some are better than others. And that's so I was thinking what we could do, but military style. And just have everybody, this is a little tedious though, have everybody do just one muscle so I can look at everybody. And not like doing a bunch of other stuff. You guys could adhere to that. We'll just be very, we can get through all of them and make sure that everybody's setting up the way it's on. We can do muscles, all the muscles in the back of the body, front of the body, standing, all the muscles we've learned up to now. Okay. I'm going to take a short break first. I want some water. But yeah, but you know, he's running across. I would have to see that. I mean, it's it's bad. Now it's running faster. That was something I have to see. Now I know if he is running cross crawl, but his arms are doing more swinging back, that's kind of sprinting. That's completely easier. And that what you're doing is you're using arm momentum. But you can imagine, I mean, just walking this way. Are you sure that's discharge? But he's doing this.
Which is not a big deal, even though it's bad.
Yeah.
Yes.
Well,
He's like, no,
So what I would do is I test for strong. Of the
yeah. I mean, it's just red. I don't like the.
and then,
It's just a sense of
and then, but normally you take a person who's a normal neurological state and
there's here.
test muscles, you have them cross crawl. Normally, it can have this lateral. I look where the
It heals on the shoulder thing, like, so we would want them to go here, and then we're supposed to shop two in one, 3 meters.
Whoa.
So I should not have done that when I was, on.
Yeah.
Well,
So your body, so like,
what way to do it?
so some people, I was like, and I can't get down.
And then they're gonna stay weak. And then you just.
Which technically, like, through like squat, like, so like basically you just like raise your heels up so you can go over and you're not falling. Yeah, and then roll over like.
No, I just, we got, I just have, I just, normally.
Put them on that and you still see. So, and then he'll go into like, walk.
Okay. What?
Yeah, or like, small breaths, like any mobility in your extremities or stabilization. That's one of those. Probably just be an effective. Exactly. And you can do exercise for some years to do it. Did some people that would do that?
Matt, you can pay until
Yeah,
tomorrow.
we'll go over everything.
Yeah, I messaged you. Like, the first thing I messaged you.
I'm asking. I don't think it's like urgent. I just
I
think
feel
it's
like it's a gap in my knowledge that I want to learn more about.
Okay.
He was swimming.
You was.
Slow motion dreams.
Sure.
Sometimes it's scary.
Yeah, just like 10. Yeah, you guys been out.
Can you stop, please?
Yeah. After.
That's great.
I know, but, I know.
That's too bad.
Making sure that that's not
Because
true.
it isn't, yeah. So
But it is.
well, that was strange. This is something I don't see that.
Great.
Yeah, okay, so that's. They'll let me do that, that's. Well, it is kind of complicated, you don't know why. But, what we do is
I would try not to.
oh, so.
He's drunk.
Degenerate. Still strong. Yeah. She's still awful.
You did that,
Yeah.
didn't
Most people here.
Checking something on YouTube.
That's really what it comes down to.
Yeah.
Catch me on the weekend, that's the closest I get. Degeneracy.
Right next to Danbury. She grew up there. Yeah, and then she, Canada Lake. You're what town? So,
The bar.
I'm still recovering
Yeah.
mentally and physically.
so.
Are you fixing the gate?
We're finding out, we're gonna wait until everybody's back. I bet you this.
Yeah.
I really. There you go.
I was thinking that.
That negated. So you did regular cross poly, you strengthened the student base. Perfect. Perfect. Good job. Good job. Yeah. So we got to fix that. Well, that's fine. Yeah. Yeah, we got right back to us. So what do you do? I need to switch my stuff.
So this will be in-house?
there was one that does. He's not, but we can. I think it's I think it's yeah, yeah, I did. Yeah, Maria. You're just like. You're probably right. Yeah. I'm like, I'm sure I'm certain, and then I'll see it like. You were certain.
I'm sure you these guys and then we'll get the muscle test. And then maybe, what we'll do is we'll show this. And then do the muscle test. And then she's, Elle's gonna get to see the dose of your correction in your. Sure. Okay, so where is? Well, that's now.
You might not want to. Oh, that's. Not the A-lines. Oh, yeah. It was. Wait, what did you have? Yeah, you're right. Oh, sure.
Yeah. Yeah.
I already know.
Yeah.
I think literally.
See stuff. Yeah. Whenever like stuff's like coming out, I'll take it off my phone.
Yes. Yeah, I'm always like,
I will go find it. I will. Oh, yeah. Well, you need. It works. My body's like finding this like organic alignment. Breath in, breath out. So where is? Elle. Sorry. Hey guys, I'm ready to. Ready to rock. So guys, I want to do one thing before we go into the muscle test. Our two willing volunteers here, Elle and Tiana, well, you guys, and we can all do it with you, but so here's what we found during the break. I tested some strong and some weak muscles on Elle first, and then I had her cross crawl. And she had weak neck extensor. You had several things that were weak in the clip. Had her cross crawl. Nothing strengthened. So you had a weak lat and a weak right serratus in the clip. And those didn't. That's super. Oh, okay. Neck is, yeah. So those were weak in the clip. We had you cross crawl regular, 10, 15 reps, and everything went. Those didn't turn on, and a bunch of other muscles. I think nothing came on. Right. Then I had her do homolateral cross crawl, and I did it with her. Felt kind of weird. Did what, 10 or so. Everything turned on. So we did the same thing with Tiana. You didn't really have any weak muscles at the start. And then you did cross crawl and everything blew up. And she did homolateral crawl and everything. So both of these guys strengthened with this game. Now that's not okay with me. So Michaela found that spinobasilar fixation negated the effect. And how we did that is after we found out that the homolateral strengthened them, we had them do cross crawl again, which brought back the weakness. Spinobasilar negated L's weakness. Motions, the motional TL, Tiana's. So now what I want to do, we can actually, I guess we don't need to do that again, just to work to weaken you on purpose. But what we're going to do is during lunch or after we do the muscle testing, Elle will get her spinobasilar corrected, and Tiana is going to get an NET clearing expert, ET practitioners. And then after lunch, we'll retest and see if we fixed it. So, and if we do, which I think we're probably going to, better, right? Then their job is going to be to do cross crawl to reset that pattern in the systems over the next 3 weeks to 3 weeks. And so we're wanting to reprogram their gait pattern. And we don't know when gait patterning stops. This could be your normal for me. I didn't know I was left eye dominant until I was in my 40s. I just assumed I was right eye dominant. Finally, I did the test, I'm left eye dominant, right-handed left eye dominant. So there's nothing wrong with that. It's just that it really helps to know, especially if you're trying to cite something. So let's do all the muscles. What I want to do is use a willing model. Oh, we've got equal number in here. Where are we at? 6, 7, 8. I can use you, but I want you to help me.
How many people are here? I missed it.
Did you count you? I almost did. Okay, so I'll use L. And so what we'll do is we'll start with your pair up. We want to do this really orderly, so don't go off into random. Next thing I'll look over, somebody's adjusting somebody's left ear or something. That's great. I love seeing the kind of. But let's just keep this really, because I want to make sure everybody. This is for me to evaluate how your setups are. So going forward, that I know that you're really dialing in your. And don't be surprised if I come around and correct you. So I want to make sure you're doing well. So I will test on. Because I want her to help me with practice. Well, we won't be walking around too much because we're going to go through pretty quick. So we're going to show the muscle test, and then I'm going to make sure I see everybody doing it. And if we do that, if we do it orderly, we You'll help.
I'm so
Okay. So let me get kind of centered more.
I don't know.
Maybe I'll get on one of these.
Whatever, I'm here for design. I'm lost.
You know, kind of slip off into the shadow.
No, I have the shadows. I have and I also reach out to him sometimes. He's military style. Let's see how long it's how you want me to talk to him. Last time he did awesome. Well, yeah, since he's local and not.
Oh, it's right there.
Yeah.
Let's start with seated. With your patient seated. And the doctor is going to be behind the patient. Everyone seated, doctor behind the patient. Okay, we're going to start with like session 1, real basic. Everyone do the right deltoid. Everybody's just freeze frame with your setup. Right deltoid. Elbow up. There you go. Nice. Everybody looks. Chris? Yeah, make sure your contact is high or low. We don't want this joint here, but you don't want to left deltoid. The deltoid should look just like the right, and it does. Okay. Now, we are going to go ahead and test the right posterior. I want to see that. Yeah, nice. So if your elbow sets the lines up. Okay, so anterior deltoid. Usually I like, you can do it from the back, or a lot of times you want to step just to the side. But if you really want to get a really accurate test. And of course, the left side, posterior delt. Posterior delt.
Anterior delt.
Usually rotating. But,
yeah, and you can make sure to
the actual delt, make sure you're.
Yes, yeah.
Unless you're super talented. But, okay, so we're coming up to the neck. Everybody ready? So we're going to the head and neck. Okay, you're going to tip the head forward and turn it to the left. Now, there was two options with this. You can become inductively if you used to do it this way. Put the elbows to stay, lightly pressing the elbows into the top of the shoulders. Hold. Right scalings. Turning this way. Left scalings. Now, if you do it one-handed, you can have your stabilizing hand here. And I would do the right with my right hand, the left with my left hand. You get the nicest results out of it. Everybody's scaling. Everybody go good? It's flexion, about 30 degrees rotation. Now we didn't, eventually we'll break down anterior, middle, and posterior scaling, but for now. Now, head comes forward all the way, fully rotates to the left. Now here's one way to do the SCM from behind. Stabilize, and you're just kind of like bringing your patient's head towards you. Good. Now, if you do it standing, I would recommend sitting around the side of the patient using your neck. But you can do it from behind, but make sure you're very precise with your pressure. Now, since we're here, bring your patient's head into extension. Now, a lot of times they are sort of, they're not lordosed, so maybe have a lift up through their low back. Thank you. I'm right-handed, so I'm going to use my right hand, but left forearm gently across the collarbone area.
Don't choke your patient.
Don't choke your patient like I did yesterday on somebody. Don't do that. What's that? Oh, she's not here. The bright ones, yes. Yeah, I choked her. Oh, God. Okay, so make sure you're not going to choke your patient. This hand, I'll do it left hand. This hand, clear down here. Hold. See, this turned on when she did the cross. It's going to be interesting. So neck extension. Turn and have them extend and then turn to the right. Extend and turn to the right. And you want your, okay, so vector right here. So elbow right along the spine, and you're pushing up and over. You got that? Not like this, like this. Everybody's got it. Okay. All right. So from here, what else do we do? Upper trap. Thank you. You can do it standing too. Put your hand on top of their shoulder. Have them lift their shoulder. Head turns about 10, 15 degrees away, and ear towards the shoulder. Reach up over the head. Pull the shoulder and the head apart. So the other side, shoulder comes up. That vector is like this. So it's hard to do this on standing people. On standing, if your people are taller. Okay, so go ahead and lay. Put your patient face.
Yeah. Thank you.
See, that's what the track does. Track.
Thank you. Witnesses, this is a third offense. Yeah, you're not. Yeah, look at this.
I like this part.
There's always a troublemaker too.
Gee, you can crash. I'm lying. No, you thought, there's enough to say.
Okay. Everybody, listen to me. Okay. So you're standing on the side of your patient. You have access to their hamstrings. Bring the leg up about 40 degrees. Hold. And see my arm? Straight arm. And if you get a good lock, you just lean into it a little bit. Big muscle. Push, push. And all these tests, you want to ease into it. 2 to 3 second crescendo of pressure. Now, you're going to bring your patient's leg up off the table, stabilize their back. Now, I've showed you this, I think, first. Sometimes you come in through like this and hold it like this, and then they get into that position, and then you get test the glute max. You're stabilizing on the left, on the opposite force. Do both sides. Easier if you go to the side you're testing. They get really way over. Okay, now you're going to test. Everybody with me? Piriformis on the left. Prone piriformis test. Bring the knee out just a few degrees from, if it's right up against its partner, bring it out just a few degrees. Bring the ankle clear across to where it comes to the end of its range of motion. Get a hold of the inside of the left ankle, stabilize the opposite thigh, and pull the ankle towards you. That's strong. Now, be careful with your contact, how you're grabbing it. Broad contact, stay above the malleolus a little bit. Or right at it.
You can do it. Good.
All right. So we have glute max, we got piriformis. Now, we're going to, we're going to go from like first session to yesterday. Your patients get down, have them lift their right shoulder off the table and then bring their head and neck with it. Try to keep their head and neck in neutral if you can. Stabilize their left thigh and then test through the right shoulder. Right. Yes. Do both sides. You're going to be on the opposite side you're testing. Don't test equal to one side. The rest.
Very strong.
Everybody got that? Same for spinal. What was that?
I don't know.
What? Okay, so now we're going to take your patient's left arm out to the side, and you're going to externally rotate it where their thumb is pointing upward. They're going to turn their head towards that left arm. You're going to stabilize the opposite shoulder. You're going to push down. This is, and you won't need much pressure. This is middle track. Remember middle track?
Yeah, you're going straight down. Yep, perfect.
These will find weak blocking.
No.
Everybody got it?
Yes. Yeah, because I know it's a little confusing.
Yes. Now, guys, hey, listen to me. Dr. Fred, listen to me. That was middle trap. You're going to do lower trap. You can go from one to the next. So lower trap, you bring the arm up into this position. You're going to stabilize here. You're going to push as if the arms would go towards the front. These you often find weak as well.
Yeah. Okay. So lower trap now, you're in this position. And same thing, you're going to push down, but now the vector's like towards their face. Like this.
We'll do that.
Oh, you're okay. Can I use this arm? You're going to be in this position, right there for me. And then push up towards the
Hey guys, put your patient on the back. We're trying to get through these. Oh, we got 30 minutes by my estimation to get through all of the muscles. Get through them, switch. Let's go really fast. So your patient is supine. What can you test supine? All kinds of stuff. We will start with the pectoralis major provision. Everybody do that muscle, just that muscle, and do the other stuff.
And on the opposite side that you're testing.
On the opposite side, you get the opposite.
Jennifer, turn that arm.
Watch your hip contact.
Switch your hands. So you're, yep, beautiful.
No, it's.
Yeah, what's that? Yeah.
So from pec major to proximal,
I would either go here or here, but still.
same side, pec major sternum. And you could do the test just almost like pec major clavicular vein, aim it towards his hips, change your stabilizer hand, and test it. You change the vector, you don't change the body position. I mean, the patient's arm. Pec major clavicular, towards the Technique. Bang, 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 right in the rub.
You're trying to keep us up.
You're trying to push it out. Because my
Okay.
tennis is not showing.
Everybody got it?
Yes.
You're gonna push this.
It's lower track, right?
Yes.
Be sure. Okay. We're moving down to the lower extremities. Now we're going to start with the rectus abdominis. So you want your knee, what? Greater than 90, less than 90, whatever. You want the knee, you don't want 90, you want it a little less than 90. And you test that away. And then you do the other side, test the rectus separate. And then you're going to use the opposite knee as a fulcrum. You're going to test the quads as a group. And in this situation, you want the knee at 90. These quads will, we've got the game.
She wouldn't give me the leg.
I thought she was already testing, so I was just like, no.
So guys, watch just for a sec here. So,
Oh.
and this is, most of the time it'll work just kind of doing this, but if you got somebody super strong, bring that elbow above. So you come in here pushing my hand, and then you can actually use your body test. You got a really strong person. I've tested people where I go to test and they literally let them off. And obviously the quads work. But, so, quads, rectus femoris, and then quads as a group. Bring your right leg up, full external rotation. Supine piriformis. Supine piriformis. Stabilize with your left hand, or whichever side you guys are. We're on the left side. Left hand stabilizes the knee. Get a hold, a broad contact hold. Hold. They'll compensate by flexing, by adducting, anything they can do it. It's good if you can do it from the same side. Supine piriformis. Now, bring your patient's right leg up straight, 30 degrees flexion, 30 degrees abduction, full external rotation. Stabilize the opposite pelvis. Have them hold first and then do the test. The psoas major. Make sure they can hold the muscle, like you can take your hand away before you test it. Go back. They can't hold it. Your test is already done. You don't want to hold it.
Yeah, I'm getting hard sometimes. Give me that.
Now, yeah, next muscle is okay, good. Next muscle, iliacus. You can go from the psoas and just bring it into neutral position as far as adduction and abduction. Full external rotation, 30 degrees flexion, stabilize the opposite pelvis. Yes. Now, the iliacus on the right is associated with what syndrome? Or what particular part of the body that we talked about last night? Right iliacus. So one of the reasons reasons, an ICV will act like a disc. So, psoas iliacus, rectus quads. Okay, come to the foot of the table. You're going to pick up their left leg, hold it internally rotated, bring it about 15 to 20 degrees abduction, abducted about 23 degrees flexion. Hold that right there. They can hold it. Stabilize their opposite leg. Push that leg towards medial and down. That's the tensor fascial lock. Tensor fascial latex. Big stroke. Okay, so still at the head of the tail of the table, foot of the table, tail of the table. Bring your patient's right leg into adduction, a little bit of extension. Reach down and get as strong a vector as you can with your elbow out and test the gluteus medius. Gluteus medius. Okay, now standing at the head of the table, the tail of the table, foot of the table, you're going to move up towards the lower right side of the table. I'm trying to be a military student. And I want you to hold the patient's ankle in neutral. Knee is about 90 degrees flexed. You're going to test the hamstrings supines. Hand on the knee. You're going to internally rotate the tibia, and you're going to change your vector slightly, emphasizing the medial hamstring. Externally rotate the tibia. Change hands. Test the lateral. Hamstring as a group. Medial, lateral. Okay, now with that same position, starting position, fully plantar flex the foot. Get a hold of the calcaneus, stabilize the knee, and bring your vector down low and pull straight back. Testing the gastrocnemius. Gastrocnemius. Okay. Now, are we ready to go into the foot? What's that? Oh, okay. Let's do circulation gracilis and then move down the foot. Okay. Oh, and also adductors. Now, this is the cheap adductor. It works really well most of the time. Hold that right there. I push out the left. I push out the left. We're testing adductors as a group. The other way to test, of course, is side body.
Yeah, cross your hands. Yep. Yep. Nice. Very nice.
The gracilis is
I can't see the name.
We ready?
What are we doing?
Next muscle,
Sartorius. Here we go.
Sartorius. Hold there. See my stabilizing hand. See where my elbow is. Right against knee. See, I'm really close to their knee. I pick this up. I will often do this a few times so the patient gets the motion I'm going through. I'll have them hold. And I'm using both hands. If you just pull on the lower hand, the lower contact, you're mainly testing the hamstrings. And also you want this knee less, you don't want a full 90, you want less than 90. Their heel will line up just south of the knee. Okay, now. Oh, okay. Okay, Okay, so now you're on the right side, right lower side of the table. Your patients, you're gonna shift their both legs over, kind of like we're gonna set up the test and chew out, which we're gonna do next. But you shift the patient's legs over this way, you get real low, you stabilize the opposite leg, you are doing broad contact just above their ankle, and you're testing the wrists. Now they need to be internally rotated at the hip. If they aren't enough, then you end up testing mostly adductors. Now sometimes it's a little difficult to ferret out adductors or but now we haven't learned this one yet. Now we'll learn. Go. The popliteus. I always test these and then I go right into the popliteus. Popliteus is your knees at 90, full internal rotation of the tibia. Get a capture of the entire ankle with your forearm and your foot like so, and then you rotate out. Now, you're trying to rotate the tibia, often the foot lets go, so this is tricky one. We'll learn this one really well. Yeah, last. Yeah, last. Okay. 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 All right. So let's move down to the foot ankle. Okay. So remember, there's 4 ways the foot can go. Up and over the other way, down and over the other. Four directions. The up and in is the tib anterior. You curl the toes down, the tib anterior. You're at the very foot of the table. Stabilize their ankle. Come up and over, hold them. And the same thing, do the other side, up and over. Now, while you're there, bring the foot into full eversion and dorsiflexion. Pull the toes down. This muscle is what muscle? Tertius. The tertius.
Oh.
Now, the foot is flexed fully and everted. Your vector is coming out from the side and below, and that is your peroneus longus and brevis. Peroneus longus and brevis. Now you will find these, if you get good at these, you'll find them weak a lot. When you first start testing them, a lot of times it's hard to find weakness. Guaranteed you will find them. After you do, if you get good at these, there's a lot of weak nasal muscles up. Right, we'll start with the right one here. Okay. Fully flexed and inverted. This is your tibialis posterior. This is where you bring the opposite leg off the table out of your way. You can get your vector way down low. It's nice to even have the foot a little off the table. Tibialis posterior, related to what organ? Meridian. And what meridian? Pericardium. Now, what's the meridian related to the peroneus? Peroneus and tib anterior both share the same meridian. Organ relationship. Bladder. Bladder. Okay, most of the foot and ankle muscles are bladder. Tib anterior, peroneus longus and brevis, bladder. Tib posterior is adrenal. Gastroc is adrenal. Gastroc facilities. Okay, so we've done the peroneus, tib posterior, tib anterior, tertius, right? We've done all everybody's done all. Okay, now get down low, get a hold of one of your patient's feet, and you're going to grab, like I'm on her right foot, I'm going to take my right hand, get a hold of her right hand. And I'm going to kind of work my hand up until I can stabilize her first ray really well. Take my other hand and get a hold of the proximal segment of that. And I'm going to move it back and forth first to just check and see if she has paralysis limitus. And then you're going to have the flex, and you're going to try to move at that proximal. Okay. Now you're going to move your hand up to where you're stabilizing now the first ray and the proximal segment, and you're going to test the very distal segment of that. So often you'll find 1 week or not. Do the other side too. This time you take your left hand to your left, patient's left leg. Get a good capture up here, flexion. Come up to now stabilize the proximals and flexion. And that was kind of weak.
Yeah, that was
Yeah, like the joint has popped off. Yeah.
Now, go good so far? Now you're going to take your right hand again on that right foot. I want you to extend the proximal segment and hold it there, and you're going to try to bring that into flex. And that's your extensor hallucis rex. Then you're going to go same thing, bring your hand up to the stabilizing the proximal, have that extend, and you're going to try to bend. That's your extensor. Okay. I think that's all of them. I'm sure we missed something. Oh, what's that? Yes, yes. This is how I flex. Have them grip your fingertips with their toes, and you try to take them out. And have them extend their toes and fold them over. It's pretty cool. That's how okay. So, I know what we did the pec major, sternal, and clavicular. We didn't do the pec minor. Okay. Remember pec minor? Hold there. They're kind of up and over. And you're going to stabilize the opposite shoulder. I prefer you're on the side of your testing. You can do cross body, but especially when you're learning, make sure they're protracting from that shoulder. If they're just doing this, they need now have your patient sit end of the table. Oh, thank you. Everybody, don't have your patients stay where they are. Okay, I almost forgot. New muscle, QL. QL. Hold there. Hey guys, lastly, then we're going to switch. I want you to have your patients sitting on the end of the table. You're going to be facing them. They're going to bring their arms into a folded position. You're going to turn them just slightly, about 10 or 15. You're standing directly in front of you. Lock their two knees. You're going to straight back for the right rectus abdominis. Right, and then turn in the other direction for the left rectus abdominis. Now you're going to turn them to, holy gosh, what's going on in this? You know, she used to never listen. I would try to use her and she'd come up with weird stuff. Now she's wants to be my friend. Okay, so you're over to the right side of your patient. They're turning to the right. You're going to brace their knees. You're going to push. I usually like to get a contact over their left upper arm and wrist, kind of broadly. And I'm going to push them away to test their left external oblique and right internal oblique. Yeah. And turn them to the other side. Step over to the left side of them. Raise their knees, push through, testing their right external oblique and left internal oblique. Now, you remember from session 1, the rectus abdominis, remember the cranial that's associated with that? Sham sagittal suture. And so if you have, we didn't have a weekend. Yeah, we had a weekend. So if we were weak, which we're not, arch your back. Usually, if you extend, yeah, there it is. Now breathe in through your nose, hold the breath. So that would be a test. And then you go to the sagittal suture. Now you can test it, you can TL it, but it always needs separate. It's direct correction, not a rebound. So as they breathe in, the bones normally do this on each breath, cranial motion. As they breathe in, ride that out several times. Encourage that opening and retest. A lot of times it'll bring those abdominals right back. So rectus abdominis, sagittal suture, that probably will be on your test. What's that? I write it? No, I didn't. I have like 3 different versions of the 100-hour plan. The ICA gave us. And for a price. Come on, let's see. Come on, roll a few numbers around. I probably want to wait till I retire. Move to a different country. Yes. Oh, sure. Yeah. If you spread it and release it, you'll get a rebound challenge. But then the correction is direct, which is different than the others where we correct and the correction is rebound. So. No, it's the same. Yeah, yeah. So yeah, no, never mind. Scratch that. With the other cranials, we're using a rebound correction. So we're actually going opposite to the normal motion. These were just, and the same with the sacral. With the sacral inspiration assist, for example, it's a direct correction. There's about 3 or 4 cranials that are direct correction, not, it gets confusing. Okay. Well, your correction